Hi, this is Ben Boyer. I'm going to be moderating today's part 3 of the Guide to Infection Prevention. Just want to give everyone an extra minute to join us, but we'll start quite soon. And ahead of time, thank you all for taking some time out of your day to hear this. Wait another 10 seconds or so, and then I'll go ahead and kick it off. All right, I think that's enough time. So my name is Ben Boyer. As I said, I'm one of the co-founders of R0, and it looks like I went too far up on the presentation. The goal today is to talk about infection prevention. In terms of the way the presentation is structured is brief introduction, why now, understanding the new ASHRAE 241 requirements, the role of data and next steps for compliance, and then question and answer. I will go through the slides pretty quickly to ensure that we have time at the end to answer any questions that people might have. In terms of my background, as I mentioned, I'm one of the co-founders of R0. In terms of R0, the business was originally stood up as a response to COVID back in early 2020 as the world was struggling to figure out how to reopen. My co-founders and I decided to build a business that would help with just that. I became a student of infection prevention in hospitals to understand how they mitigate the spread of infectious disease. And what came out of those efforts was R0. What was interesting in speaking to a lot of people in facilities operations, and then specifically in infection prevention and healthcare, was that all hospitals view the problem in the same way. In their minds, there are 3 dimensions to risk or pathogen spread: hands, air, and surfaces. And they all have very similar measures or interventions that they brought to bear to mitigate the spread. I was expecting to find a lot of technology within the hospital. The reality is I found a lot of chemicals, some filters, and a lot of rules or protocols. But what I did come across was UVC light being implemented in many of the hospitals with the lowest incidence of HAIs. That was incredibly interesting to me. And in learning more about UVC, I understood why. It's an incredibly old technology. The Nobel Prize in Medicine was awarded to someone in 1903 for his work with germicidal UV. It's been used to treat wastewater since the 1910s, HVAC since the 1920s. And so the body of evidence for its efficacy is unquestionable. It's very deep. The reason why I was so focused on hospitals was ever since the advent of the hospital, it's the one communal gathering place for the sick. And if generally speaking, everyone on this call can go into a hospital and receive care, despite the fact within the 4 walls of the hospital, you have C. diff, pneumonia, MRSA, Candida auris, then maybe they would know how to mitigate the spread. And maybe they would have the answer as to how to get my kid back into school, get myself to be able to use an office again. So long story short, that is the beginnings of R0. And today we are protecting well over 1 million square feet of real estate across a whole bunch of different types of organizations, from hospitals, corrections, schools, you name it, we probably have a customer. So why now? Well, it's interesting as I got smarter on disinfection in working on R0. what I came to realize is, the human body or humans consume somewhere around 2 to 3 liters of water every day. But we breathe 11,000 liters on average of air. And the water that we're drinking has all been disinfected. There's very strict regulations to ensure that the water we consume goes through a very protracted process to ensure safety. With the air we breathe, there's not, despite the fact we're in essence consuming a lot more of it. This was a realization that really took force in my mind around the pandemic. And this inability to bring people back together safely, and the fact that we were seeing outbreaks, and we continue to see outbreaks. And if there was a pathogen in the water, as opposed to in the air, it would have been mitigated. And it doesn't need to be that way. And so, the why now is really COVID as a moment in time, I think, opened up my eyes, and I would say R0's eyes, as to what the real challenge is, and really has forced us as a company to think about ways that we could help organizations address it. If this issue around the air we breathe, if we weren't an indoor species, it wouldn't be an issue. But the reality is we spend 90% of our time indoors. So the decisions that are made by a head of facilities or head of real estate probably have a greater impact on our ability to stay safe or get sick than our own general practitioner. So it's incredibly important that we start realizing that this time we're spending indoors is really going to define whether or not people get sick, and ultimately, as long as we continue to be this indoor species, we're going to have to think about air in the same way that we think about water. The other great learning that came out of the early work of R0 was understanding that poor disinfection is incredibly expensive. The $150 billion number is really around lost productivity from sick days. HAIs alone, or healthcare acquired infections, add an additional, I think it's $30 billion. And so you're talking about almost $200 billion just in the United States is sort of lost or spent or wasted because we're not doing what we need to be doing from a disinfection perspective. The good news is in the wake of COVID, if there is any good, its organizations are really starting to prioritize issues like indoor health and the air that we're breathing. And so we are starting to see things change. The existing methods to dealing with IAQ issues really come down to HVAC. And what's interesting about that is, it's incredibly expensive, and that's defined both from an energy consumption perspective, but also the greenhouse gas emissions that the energy is producing. But it's incredibly inefficient. The filter that was developed for HVAC systems, it was never intended to be something to disinfect the air. In fact, it wasn't really intended to be something to purify the air. The filter was first developed to act as a safeguard to ensure that small particulate wasn't hitting the mechanical, and it was in essence an attempt to extend the life of your HVAC system. Today, it's being used more and more as an intervention to protect human health. And in some respects it can, in others it can't. But irregardless of your views around the capability of purification as it pertains to viruses, it's incredibly inefficient. We have a customer that shared with us some data. It's a very large and well-known software company. And their post-COVID intervention has been to move from MERV 8 filters to MERV 13 and to bring in 100% outside air. This is costing them 30 to 40% more energy consumption per facility. And that is ultimately something that they've now adopted and will have to continue to spend money on in that same capacity forever. The CDC, ASHRAE, and Lancet also we're viewing the issues around indoor air like everyone at R0 was, that more had to be done. It's very well known that if you increase ventilation, you have less illness. And it makes sense because you're diluting down or disinfecting the air that you're sharing with your coworkers, with patients, with people in your environment. I'll mention a little bit about all three of the standards. They're all a little bit different, but really the focus is on ASHRAE, because what ASHRAE comes up with ultimately becomes our building codes. For those that don't know, ASHRAE is an organization of HVAC engineers, and as I said, they do set the standards that become code. The ASHRAE 241 is in essence a supplement to the previous standard, which was 62.1. 62.1 set what we call the minimum viable ventilation rate for the built environment. And that was written in 1973. In 1973, they were focused on, in essence, two things and sort of an overarching thing. One was thermal comfort, so what level of ventilation is required to sort of get the air to the appropriate temperature, either heated or cooled. The other was what level of ventilation is required to remove body odor, so you're not smelling your coworkers when you're at work. The overarching goal with both of those was to reduce energy consumption. So in the 1970s, we were going through the energy crisis, and so that ultimately was driving a lot of the regulations. That has been the standard up until 241, which came out in the middle of this past year. 241 took a different approach to looking at the problem. If you in essence only ventilate to the 62.1 standard, this minimum level, you are doing nothing to help prevent the spread of infectious disease within the built environment. I'll go through what the changes are, but they're monumental. And that's a very clear acknowledgement that if you want to have a healthy space, one where you have the ability to bring people together safely and not expect everyone to get sick consistently, then you're going to have to do a lot more from a ventilation perspective. The CDC also came out with their standard, whereas ASHRAE looks at it by building type and room type, so how the space is being utilized. A gym is very different than a corporate office. The CDC just tried to come up with a number that if you wanted to have a sort of a minimum healthy building, you would have 5 equivalent air changes per hour, and you would be operating at a MERV 13 level. The Lancet came out with their own numbers, and they are offering a good, better, best perspective, with good being a minimum of 4 EACH, and best being something over 6. So in terms of the ASHRAE requirements, just to begin with, and I mentioned a little of this before, pathogens are primarily transmitted against three vectors. Surfaces, that tends to be bacterial infections, so C. diff, MRSA, C. aureus. Those are areas that those are pathogen types that typically are passed through surfaces. The airborne transmission route are really your traditional viruses. This is going to be COVID, influenza, RSV, tuberculosis, the common cold. And then you obviously have the person-to-person infection risk as well. And some of this can be mitigated through hand hygiene. The reality is a lot of this is actually bloodborne, and there's very little in the way of a disinfection company's ability to mitigate the spread of those types of pathogens. The standard that ASHRAE came up with was quite interesting. So rather than look at a space as a whole, as I mentioned, like the CDC did, ASHRAE looked at it by building type, industry, how spaces were being utilized. And what they came up with were numbers that are significantly higher than where 62.1 or 170 is the healthcare standard, 62.1 is for the rest of commercial real estate, where those levels of ventilation had previously been. a classroom going from roughly 3 EACH to 8.3 is a monumental increase. Healthcare also saw significant increases, and the one to call out is the waiting room in a healthcare environment. 12 EACH to 40. The reality is when you're up around 12, you've lost the ability to impact air via HVAC alone. You're going to have to look for supplemental technologies that can create additional levels of disinfection or purification. But 40 EACH, if you're in an office or in a waiting room with 40, and it's all coming from central HVAC, it would be like sitting in a wind tunnel. It's not feasible. Offices are very poorly ventilated today, among the worst of any of the physical space types. Our customers have terrible air on average before we help them to increase that number. And that's the reason why we have 30 to 40 million cases of influenza every year, and people typically get sick at work. The office is just really underventilated. And then, as you can see, public assembly, religious institutions, those are other areas where you just saw a tremendous amount of additional ventilation requirements. The ways to comply with ASHRAE 241. So 241 provides the roadmap as to what different room types need to get to, but it doesn't explicitly say how to do so. And so, there really are, I'd say, 3 basic ways that you can try to move up in terms of ventilation rate to hit that compliance. One is to increase the ventilation from your HVAC systems. Not all systems can actually increase. A bunch of our customers use older systems, and they're not variable fan speed, and so they just run either on or off. And even if you are in a situation where you can increase the output of the ventilation from the HVAC, it's typically in the order of an air change per hour is what you would get out of that. As I highlighted previously, it's very expensive to do that. It's going to consume a lot of energy. And that's going to have a great impact on greenhouse gas emissions and whatever your sustainability posture is. But there really is a limit as to what your existing ventilation system can achieve. You can obviously rip it all out and build something new, and that can get you to higher levels of air change per hour. The reality is you're again going to run into the energy issue. You're again going to run into the sustainability issue. And then there's obviously the cost of ripping out the old. Portable filters is another way to go. The very best high-end healthcare focused ones will get you 3 equivalent air changes per hour in a reasonable size room. Most of the ones that we see are closer to 1. But that assumes that you run the device at 100%. And so that's one of the dirty secrets about the filtration or the portable filter market is all of the claims data that they show on their website or on the box assumes that the device is running at 100%. Most of our customers have had portable filters. I would say the vast preponderance don't use them anymore. And the reason why they're not utilizing them is sound. They're very noisy if you run those things as they're supposed to be. And so classrooms in particular, it's been a real issue for student learning. When you're running them, there's some classrooms that have multiple filters, or at least try to implement that to get some additional EACH. And the reality is it just wasn't working as it pertains to student learning. You also have upper room systems. And so we built the most powerful upper room system on the market today. This is a technology that creates a zone of irradiance above your head, and it's able to disinfect a huge volume of air. We conservatively put in a 10 EACH addition with that product. The reality is we have a customer that I believe has achieved 18. So it is incredibly capable. When we built this product, we actually did so modeling it after the technology that was used in a very famous study by Dr. Wells during the measles epidemic in the Philadelphia schools. During that period of time, there was a massive epidemic, and Dr. Wells implemented upper room UVGI or zones of irradiance above students in these schools, and saw, I think it was an 80% reduction in the spread of measles in the classrooms that were protected. We basically built a better version of that same technology. The reason why we focus on UVC is really because it works. There's very few technologies that were ideated in the 1800s that are still being implemented today as sort of a best-in-class technology, and UVC is one of them. As I mentioned, Nobel Prize in 1903. Systems like ours, I think, first started to show up in healthcare in the 1950s. And during that time, what we've come to realize is there's no pathogen on the face of the earth that has resistance to it, and we can inactivate anything. And so, COVID is easy. Like most viruses, we can get mold, we can get fungus, odor-causing bacteria. We have a UVC system that produces what's called FAR UV. It's a human-safe wavelength of UVC, and it's specifically tailored for restrooms to provide this automated continuous disinfection. But the sort of investment in UVC that we're talking about here will not only help with all the common pathogens that we've just sort of accepted as being normal, norovirus and influenza and the like, but it will also protect us from what the next pandemic may be. If it's a fungus, if it's another virus, or something we can't even dream of. It's also incredibly sustainable. As we better understood this intervention of trying to do things with HVAC alone, we came to realize that the building stock in America contributes about 35% of all greenhouse gas emissions that the United States contributes. And those numbers are before COVID and the impact that we've seen by having organizations lean into HVAC to be as sort of a safeguard or a protector. So whatever those numbers were previously, we know they're going to be substantially higher going forward. And that's just not going to work. HVAC as a mechanism of heating and cooling is super important. Filtration is very important, and there should be a standard amount of that. But decoupling disinfection from purification does some really interesting things. It allows you to deal with the in-room air as opposed to just thinking about it based on the building. And in-room air makes a much bigger difference to human health and in building health. Best example of that is if you're in a conference room and you're sitting around a table and you're breathing and someone is sick, you have a much higher likelihood of getting sick or staying healthy based on what's going on from a disinfection perspective in that room than it does if the whole building has got additional filtration or the like. And so when we developed our products, we did so with the sustainability lens forward. The ARC product really replaces chemicals for chemical disinfection. Chemicals are bad for the environment. They're bad for people. There's been countless exposure lawsuits. But just transporting chemicals alone, I think a gallon of Clorox weighs almost 9 pounds. There's just a tremendous burden from a greenhouse gas emissions perspective. We can do more than what a chemical can do, and we're just using light. The Beam product is really the one that augments an HVAC investment, and the consumption of energy for that product is about the same as my laptop. So 95% more energy efficient than an HVAC system. And then with all of our products, there really is minimal waste. There's a ton of waste in plastics as you move chemicals around. There's even a fair amount of waste with filters. And the dirty little secret is in your home, you should be replacing them once a month. If it's a 1-inch filter, that's the optimum. And if you have a portable filter, it's probably every 90 days. And if it's a commercial setting, it's again, probably every 90 days. And so there's a huge cost as you start filling up the landfills with more and more filters. The role of data and compliance. So I talked a little bit about our technology. What I haven't really discussed is what makes all of it work. So as I mentioned, we have a couple of these different disinfection solutions. We have a far UV light that protects humans in the built environment, both in terms of air and surface disinfection. We have the Beam product, which is just for air, and then we have ARC, which is a tool for pathogen reset. Each of these products is IoT enabled, and so what they're doing is they're capturing data, which we can utilize in a variety of ways, and I'll cover that in a second. But before I go through the data that we're utilizing as it pertains to the endpoint disinfection, it's also important to call out that what we build from a software perspective is an ability to gain visibility into a physical space and also score it based on risk. So we believe we're the only company in the market that has built a dynamic risk model. The inputs to this risk model are dimensions of the room. We look at the mechanical, so ACH, MERV rating. We look at the baseline EACH, so if there are supplemental filters, we'll add that into it. We look at protocols, so is it a masked environment, is it not? And then we look at the type of activities that are going on. Is it people eating, or people working, or people working out? And then we also can layer on top of that IQ measures, CO2, VOCs, temperature, humidity, air pressure. All of that data it provides us with the ability to understand what are the riskiest elements of your space, and to help put forth a program where our solution is implemented to reduce the risk the greatest amount. Again, I don't believe there's another company that's in and around our space that thinks about the problem that way. Our sensors are everything from IQ to occupancy. Occupancy is really important, particularly in this hybrid work environment where people aren't necessarily using the office every single day. If you have parts of the office that are not utilized, there is no risk there. That should inform our systems and how they're operating, whether or not they're on or off. But it also should inform a janitorial workflow, whether or not you're actually having people clean. And again, with our data, we can provide that level of insight to help optimize. On the back end, what we're really providing is compliance. The ability for us to take all this sensor data, represent it back to you so you have visibility into where people go, what's going on in the air, what it means from a risk perspective, and then also to provide you with real-time understanding of what our systems are doing to ensure that we've mitigated as much risk as possible. And these things can impact things like cleaning routines, so again, the janitorial workflows, protocols with regards to how things are being managed from a cleaning perspective, and then if there is an outbreak, we'll have data about how to help contain it. We won't belabor, or I won't belabor this point much in terms of the steps to compliance, but what this lays out is we provided a general overview of how organizations may need to comply with these new guidelines. Step 1 and step 2 are basically determining your need. What's the gap between where you are and where you need to be? Step 3 is to determine the best solution to fill the gap. Steps 4 and 5 are about implementing the solution and doing the monitoring and maintenance to ensure you're providing the clean air that we all know is needed to protect building occupants, whether they be students or employees or patients or nurses or doctors. And we are here to help. So one of the things that ASHRAE is quite good at is helping you to get your arms around really where you sit today. In terms of your level of ventilation and then ultimately where you would like to go to, be it the ASHRAE Standard or some hybrid where it's the CDC minimum or ASHRAE, whichever is higher. But we're happy to help with the implementation and monitoring of all of that. And I went through it pretty quickly, so hopefully there's some questions, but let me pull up a few right now. Okay. Apologies, just reading. One, guidance around increasing indoor air changes is great, but how do you address this in older facilities that can't spend millions on retrofits? So our solution is been designed specifically for that type of implementation. So we do have customers. I know of a school in Salt Lake that doesn't even have mechanical ventilation. So they use swamp coolers for air conditioning, and they're using radiators for heat. And that's a perfect environment for us because they have no ability to actually add HVAC unless they did a massive rebuild of the entire building. So in that type of environment, we're installing Beam and Vive. So those are the two fixtures that we've developed. These are automated and continuously operating devices. They have sensors that will alert them to when they actually have to activate themselves, and they will deactivate at the end of the night, creating an audit trail of their work all throughout. And so that's a perfect profile of a customer. If you do have existing HVAC investments, and our solution is a wonderful adjunct to get more out of it. If you are a modern organization and you've achieved 3 EACH with your current HVAC system or ACH, adding a beam, in a classroom, would probably get you to 11. So you'd be even above where ASHRAE calls for, with a tremendous level of protection in that type of environment. 2 is, how can we find budgets to invest in air and surface disinfection? I think this is dependent on your business. I think one is, in certain industries there are grants, so the federal and state governments understand the challenge of where the built environment is from a protection perspective and what's needed to improve it and create a safer space. But ultimately, most of our customers are finding budget based on looking at the human elements to operating their business and trying to figure out, okay, if my absenteeism declines by a certain percentage, it could easily pay for this. If I have the ability to retain my workers, or even recruit workers that might have been afraid to work in an environment like the one that they're operating in, and they're able to recruit these people now because they are a biosafety secure environment, that's another way. But there's a number of ways to think about it. In education, funding really comes from having butts in the seat, and absenteeism leads to penalties in terms of funding. And so that's a very sort of clear and obvious one. In healthcare, HAIs are incredibly well known. People understand the risk as well as the cost, and that's another vector. But depending on the industry and your business, we definitely can help you think through all of that. But the last thing I would say is these are not that expensive of products. The Beam product we sell for $1,000. There really is nothing like that on the market today. So we're not talking about a commitment of tens of millions of dollars like a brand new HVAC deployment would be in a large district or in a large facility. What fraction of public spaces even meet the 62.1/170 standard? For example, you mentioned that 12 EACH is tough to do with HVAC. I don't have a number, but what I would tell you is based on our customers is a good portion of them, it did not even meet the 62.1 number. And so it depends on the state and how the regulators in that state are thinking about building code. Some states like California are definitely more forward-looking. Other states are I think, waiting for states like California to determine sort of what the best practice is, and then you see them implement. But ultimately, I don't have a hard number. But I would say, the majority, I think, at this point have gotten to 62.1, and ultimately, the move to 241, I'm sure will take time, but we'll see a similar pattern where you'll see a lot of adoption. 4 is UVC is an invisible technology. When a fan is running or the window is open, I can see and feel that fresh air is coming into a space, how do you get to demonstrate effectiveness and build confidence with building managers and occupants? Yeah, so we're quite good at showing the efficacy of the solutions that we provide. We can utilize sensors to show the level of UVC that's been emitted in a space, and we can also show you what that means from time to inactivate a pathogen. All of our products are tested at a third-party FDA-compliant lab. And so we don't assume anything when we build something. We just give it to a lab which utilizes live pathogens to test the actual efficacy and output of the various devices. We have testing data, a lot of it, on each of our products, and we can share it. But again, within your environment, it's very easy for us to show the level of disinfection that's going on, or the number of equivalent air changes per hour we've added in your classroom, in your operating room, in any room. This sounds great. Why isn't it more pervasive already? It's been around so long. So it's a really good question. Back in the 1950s and 60s, UVC was being utilized a lot more, and it did so with really great results. Ultimately, there was less and less interest in infection within the built environment. It was sort of a slowing downward slope that really changed with COVID. And I think that if you had asked scientists how viruses spread, they would have told you through the air. And why it took this again to get people to realize that adding ventilation would create safer spaces, but in fact it did. And so what we've seen is this, I'd say, renaissance or renewal of interest in using UVC to create this layered additional level of protection, of really separating disinfection and purification into two different buckets, optimizing both, and doing so with this concept around energy efficiency, which can create a real ROI in terms of buying the UVC products, but also what it means from a sustainability perspective. But I believe with ASHRAE 241, we're really in the beginnings of what's going to be a tremendous amount of adoption for systems like the ones we've developed. As you saw with those numbers, you're not going to get there with HVAC alone. It's just not possible. And so you're going to have to look for technologies like UVC, which can offer a tremendous amount of additional ventilation in a physical space. I think that's it from a question perspective, but I just want to thank everyone for joining today. And to the extent there's any questions that anyone has, I am happy to answer them personally. My email is very easy. It's ben@r0.com. Also, if you are interacting with anyone on the R0 team, you can obviously reach out to them as well. But ben@r0.com is my email. And thanks to everyone for joining today. I hope it was useful. And just know we're a resource to each and every one of you.